So with that, I would like to introduce our speaker today, Dr. Matthew Kinney. Dr. Kinney was born and raised in Louisville, Kentucky. After finishing medical school at the University of Louisville in 2008, he moved to Chicago, Illinois to complete a pediatrics residency at Northwestern's Feinberg School of Medicine, then associated with Children's Memorial Hospital. After residency, he gained valuable experience as a clinical staff physician for Cincinnati Children's Hospital Medical Center's Division of Emergency Medicine, but quickly realized primary care was his true calling. He returned to Louisville in 2014 as an assistant professor in U of L's Department of Pediatrics, providing care at both the CNY Clinic as well as Open Arms Children's Health, a service of the Home of the Innocents, where he serves as medical director. Dr. Kinney came to Norton Healthcare in March of 2020 as part of the integration with U of L Pediatrics and continues his service at the NCMG Clinic in the Novak building, where he has developed a special interest in addressing the disparities of infant mortality. In his spare time, you can find him with his wife, a pediatric emergency medicine physician, and 2 daughters, #GirlDad, or engrossed in his latest landscaping project, or as he calls it, playing in the yard. Dr. Kinney has no relevant relationships to disclose. And with that, I will turn it over to you, Dr. Kinney. Thank you so much for being with us today.
Thank you, McKenna, and thank you, Sandra. Thanks for everybody that can join us and watch later. I appreciate the opportunity to kind of bring this topic to light and to top of mind for everyone. So, as you stated, no relevant disclosure, so we will jump right in. So just to throw out the objectives for everyone, we're going to start by just defining what infant mortality is and how we get to those numbers. We're going to cite some local statistics and see how that measures up with the rest of the state and the country and the world. We're going to highlight a couple local disparities as well. We'll summarize influencing factors of infant mortality, kind of what affects it, what leads to it. And then, once everybody's feeling down on this dreary day, we'll move on to number 3 and 4, and we'll try to identify some local efforts and advocates that are addressing this infant mortality and the social determinants and health inequities affecting it. And, finally, at the end, we'll try to extrapolate the experience of my clinic in utilizing community partnerships to address something as broad as infant mortality. Not trying to convince you that I've saved the world or anything like that, but just try to maybe encourage and motivate other people to reach out, make connections, and help me tackle this issue as broad as it is. So here we go. So what is infant mortality? So technically, it is a probability, meaning the probability that a child will die before reaching 1 year of age. The contrast with neonatal mortality or childhood mortality, but infant mortality is before the first year of age, and it's expressed as a rate per 1,000 live births. So you'll see numbers just kind of written, assuming we all know that that's a rate per 1,000. This includes all causes, even if it's a mystery, even if it's not well defined, even if nobody has any idea what happened. Any child that dies before the first year of age included in these statistics. So in a broader sense, you could consider this an important marker of the overall health of a society. And you can see there on the right that differing parts of the world may have differing rates. That bottom line, the kind of maroon colored square, should be like the developed, quote unquote, developed regions. And it looks like the world's making dramatic progress, but I can assure you that there is work to be done worldwide and locally right here in our community. So we're gonna get into that today. So where do we rank? In the US, at least, the infant mortality, in terms of the last year that we had full data on in 2019, we're sitting right at 5.8, again, per 1,000. Where does that rank us in the world, though? Not that great. So we are 33rd out of these 36 countries termed the Organization for Economic Cooperation and Development. So considered our benchmark or our peer countries, we are nearly last in the US. And if you took our best state, Massachusetts, if you can see right here, Massachusetts sitting at about 3.8, doesn't even sniff the top 20 in the world. So like I said, there's work to be done here in our country, no doubt. Where do we find information about infant mortality for the U.S. as a whole? I would direct you to the CDC's National Vital Statistics Report. A wealth of information. There's the PDF link there. It includes, like I said, a wealth of information and graphics. There's a few of them there that we'll kind of come back to. It includes demographic information, age, race, gestational age, leading causes of death, states. Information includes all 50 states, DC, Puerto Rico, and Guam. But this is a great resource for any other questions about the U.S.'s infant mortality rates and causes. Just to drop down further into that, it actually has kind of an interactive map where you can click on a specific state and get more information. You can find other health indicators, and anything you could want to know related to infant mortality. Just click right on your state and find it there. This kind of points out initially that there's a bit of a concern here in the South, and we'll come back to that, but you might notice that this is a recurring theme with kind of different shades of colors kind of to the south of us. So again, there's your link there to the National Vital Statistics Report. So back to where do we rank? We meaning Kentucky now. Kentucky in the last couple years, we have complete data, has been around 6 to 6.6. And that's really comparable to the nation's rate as a whole. We've ranked 22nd, so in the middle in terms of ranking just the 50 states. So in the middle is where Kentucky sits currently. Well, let's go down further then. What about Jefferson County? Well, again, actually, it's pretty consistent with the state and US data. In 2017, the Jefferson County rate was 6.6. So you can see over the last few years there that we have full data for, pretty consistent with state and nationwide. But let's go a little further locally, if you don't mind. So we have a poll question here to see what anybody might think the infant mortality rate is in West Louisville specifically. So we'll give you guys some time to vote there if you can. McKenna will have to give us some details on results there, so I'll wait a moment. Oh, good. So it looks like 53% of those that voted picked 11. So that is pretty close. Thank you, McKenna. So we are right at about 11 in West Louisville, if you can believe it or not. That is high. That's why I put the exclamation point there. So basically, if I'm just counting 5 zip codes in West Louisville, and I'll show you the map here, 402, 03, 08, 10, 11, 12, the infant mortality rate was about twice as much as the rest of the city as a whole. So this map demonstrates this. This is I'll let everyone know where this map comes from in a moment. But there's something going on in this kind of northwestern part of the county, it looks like, right? So clearly a discrepancy. This does not seem to be a burden that is shared equally among the county or the citizens of the county. But 11.12, nearly twice the average of the rest of the city, the state, the country. This is a problem. So if anybody's not familiar with the geography of Louisville, this highlights the neighborhoods of Portland, Russell, California, Parkland, Chickasaw, Shawnee, Algonquin, Park Hill, Park Duval. This seems to be, like I said, the area that is bearing this burden the most. And we're going to dive into why we think that is here in a few minutes. But I wanted to throw this map on top of that and show you not just is it geographically not very equitable, but it's not a burden that's shared equitably among ethnicities and backgrounds either. And we're going to get into this a little bit further as well. So this should be concerning to everyone that it considers themselves a health or a child advocate, certainly. So Louisville Metro, just to drive this point home a little bit further, we said the US rate was about 6, Kentucky about 6.5, Louisville the same, West Louisville nearly half that. If you narrow it down to only African-American infants in 5 zip codes of West Louisville, it's darn near 14, which is striking and concerning, and a million other adjectives as well, but more than twice of the local rate for the rest of the city, state, and country. So this graph kind of demonstrates that pretty clearly. There is some inequities that need to be addressed, certainly. So this is the problem for me and for anyone, like I said, that considers themselves a health or a child advocate. 13.7 is way more than 6.6. So why is this? And hopefully everyone's forming thoughts, not opinions, but theories in their mind right now. But this is a huge discrepancy and inequity that bears some investigation, right? So before we jump back to that, let's summarize the influencing factors of infant mortality so we're all on the same page here. That National Vital Statistics report that I mentioned in 2018 listed 5 leading causes. You may find that these don't add up to 100%, but these are the leading causes, right? I want to highlight 2 specifically that we're gonna get to today, and that's the disorders related to short gestation or prematurity, and low birth weight, and then maternal complications. All of these things are important. All of these things could be a talk and a day and a week and a lifetime of passion and dedication, by themselves. But we're going to focus on these 2 a little bit more. There are other factors. Certainly, the opioid epidemic cannot be ignored. But again, we're not going to go into that really deep today. But you may notice that the first 2 things mentioned on the health outcomes on the bottom are preterm birth and low birth weight. So if you want more information on all those other factors, birth defects, sudden infant death syndrome, or what they now call sudden unexpected infant death, child abuse prevention, substance abuse, all the information is out there. It's well studied, well documented. Put that there so I can send these slides out, or McKenna can send these slides out later, but we won't go too far into those today. So let's get back to preterm delivery, and that means less than 37 weeks gestation, as well as low birth weight. So it turns out in the US, as of 2019, 1 in 10 babies was born preterm in the United States. It's a huge percentage. Kentucky specifically is the 9th highest state in terms of preterm birth rate. So that may not shock anyone, knowing where Kentucky ranks in a lot of other health outcomes. Our low birth weight rate is the 16th highest. So we're definitely in the top 16 in both of those. Again, the CDC has a wealth of information on these. You can click on specific states. You can look at the country as a whole and notice regional variations. I would draw your attention here to this swath of the South again. But if you see Kentucky's numbers there, it's one thing to say, well, we're better than Mississippi, but there's still some striking numbers there for our state. So what kind of problems does this cause? Again, without going too far into this, I just wanted to mention that there's a variety of etiologies of morbidity and mortality that can be associated with preterm delivery. I know there's folks from medical backgrounds and some folks not from medical backgrounds, but there's respiratory distress syndrome, or RDS. There's necrotizing enterocolitis, or what we call NEC. There's intraventricular hemorrhage. There's just a significantly increased risk of infection of all types when you're born preterm. The problem is the etiology of preterm labor is sometimes not certain or not entirely known. We think that infection and inflammatory processes account for up to 40%, but it can be kind of difficult to detect. It can be subclinical. But we do know that medically indicated, like induction of labors and C-sections, do account for up to 35% of preterm births. So that's usually problems with mom or fetus that basically have to be delivered to kind of resolve and save either mom or baby or both. what are risk factors for preterm delivery? There's a lot. It's a complex interplay of a million different things. It could be social, it could be behavioral, it could be clinical, it could be biologic. There's demographics. I do hesitate using race as a risk factor. I don't like to use race as a risk factor because it's much more complex than that. So I included that there because the CDC does, but I would caution you to think a little deeper on that, and we'll come back to that in a minute. But there's pregnancy issues, short intervals between pregnancies can affect this, history of preterm delivery, a host of complications from the OB/GYN world. Maternal health, certainly pre-pregnancy affects it, whether you have thyroid disease, obesity, diabetes, high blood pressure, etc. Certainly mental health as well. Lifestyle choices, kind of how healthy you are at the beginning of pregnancy certainly affects it. And then some of those habits, that if they continue during pregnancy, can affect this as well. So that is a long slide and a lot of talking to say that the etiology of preterm delivery is kind of vast and complicated, and a lot of interplay among factors. But I wanted to highlight age since we mentioned it a little bit earlier, and you'll find that the rates of infant mortality are certainly much higher with the younger moms. So under 20 is a significant increase from those kind of in their 20s and 30s. And guess what? Kentucky also in the top 10 of this health outcome or health factor. So Kentucky is the 7th highest state in terms of teen birth rate. We mentioned race, and again, I caution you to use race as it's not exactly a risk factor, but I do want to highlight discrepancies and inequities, certainly, that we're going to delve into a little bit more. So infants of African American women had the highest rate in this year's data, or in the 2017-2018 stretch. So why is that? Again, hopefully everybody's forming some thoughts and opinions and theories in their mind, but we're gonna investigate a little bit. Well, maybe it's because of an inequity in preterm birth and low birth weight. So as you can see in Louisville specifically, the preterm births, low birth weights, and subsequent infant mortality disproportionately affect African American babies. And you see on the left side here on both graphs, both low birth weight and preterm birth, there's a discrepancy. Well, okay, but why, right? Why is that? We'll see. So enter Louisville Metro's Health Equity Report from 2017. If anybody has not seen this document, please go to this website listed here from the health department. Download this, take a look at it. Again, anyone that considers themselves a health or a child advocate should be familiar with this. It is a wealth of information, and I appreciate those who took the time to do this. It's helped me a lot understand some discrepancies, not just for this talk, but for other things in our city. So they mention, or they study infant mortality pretty specifically, and they highlight these inequities, and they propose 3 contributing factors listed down there at the bottom. There's criminal justice issues, there's food systems issues, and employment and income. Now, each one of these 3 topics, again, could be studied in depth and are studied in depth, but we're going to kind of briefly mention them, jog some memories, open some eyes, and let you go research that on your own later. But one quick mention of each of these. Obviously, having a steady income, regardless of who it is in the household, helps fulfill the needs for a healthy pregnancy. It helps afford prenatal care, helps afford healthy foods. And part of it is just avoiding the stress that financial uncertainty can have on babies' growth and health. So pretty clear cut there. Not clear cut to fix, but clear cut to understand that this could be a problem. Food systems, a little bit more complex here, but obviously eating healthy foods during pregnancy helps keep mom and baby healthy. But the availability of fresh food near where you live dictates your choices, especially if you have limited access to transportation. So we know that in West and South Louisville, there's limited access to full service grocery stores. You know, there's no Whole Foods, and there's no Fresh Market, there's no Trader Joe's, there's no Paul's Fruit Market. You know, there's limited options. So this is a a map showing kind of like the relative risk. So the red areas are bad, not bad. The red areas are at risk for having kind of a ratio of convenience and fast food places to grocery stores that could be detrimental to their diet and their health. So again, that should look familiar to the area of Jefferson County that we highlighted earlier in terms of infant mortality and other things. But this one is specific to food access. You may have heard the term food desert. I like to use the term food swamp, which indicates that there are food options available, but they're not great, and they're not adequate, and they're not as good as other places in the region. So I think of these red areas as a food swamp, I guess, instead of desert. What about criminal justice? Again, we could go way in depth on this, but I had to highlight a couple papers that I found. One from 2014 indicating that having at least one parent jailed in your household during pregnancy, it could be mother or father, plays an important role in the health of the outcomes for newborn. And then it turns out that household incarceration of anybody in your house increases a risk of teenage pregnancy. And as we highlighted earlier, that can be more associated with other adverse outcomes too. If you look closely at the numbers of the U.S., especially across the southern half of the country, the numbers are shocking. I know there's been documentaries on this, but it still shocks me, the numbers of people that are incarcerated in these states. It's shocking. I don't know a better word for it right now, but this top part of this slide is kind of a confusing graph that they put together. Basically, they graphed every country in the world, but then considered each state as its own country. And the U.S. makes up like the entire top 20 or 30. No other country even gets close. And guess what? Where Kentucky is, or Kentucky is in the top 10 there. So again, there's some local factors that need to be addressed. So another poll question. This was a bit open-ended, so you may have to put some ideas in the chat. Other than the things that we mentioned already, what else could contribute to this disparity in preterm delivery and birth weight and infant mortality? Does anybody have ideas there? And just throw them in the chat, and maybe McKenna could throw some out.
You have education.
Okay.
And that's all we have for now. Anyone else want to enter anything in the chat? Lack of prenatal education.
Okay. Certainly.
Housing inequities.
Housing.
Lack of access to birth control.
Yep.
Lack of family support, 2 parents involved, grandparents.
Absolutely, sure.
Another family support. Lack of
Okay.
2-parent household. Racism, access to care. Distrust of the healthcare system. No social family support. Lack of follow-up after delivery. Lack of involvement in church.
I like all those ideas. I'm glad people were throwing those out. Thank you, McKenna. All probably contribute in one way or another. I don't know that any of those were bad ideas, certainly. But I do want to highlight one, if I could. So what else could contribute to this? And I want to pose the idea of racism and give you a couple of ideas about this. Again, this is not a talk designed to cover all of racism and all of the issues behind it by any means, but I wanted to highlight a couple things here for you guys. So this is an abstract. You don't have to read this word for word, but I wanted to highlight this from Dr. Collins, who was a program director where I did residency, super nice guy. But his conclusion from this paper was that lifelong accumulated experiences of racial discrimination by African-American women constitute an independent risk factor for preterm delivery. And so if you read this closely, this persists across socio-demographic, biomedical, behavioral characteristics, all of these things they kind of accounted for, took out confounding factors, and still by itself, just women who had experienced interpersonal discrimination and racism had more adverse effects. And if anybody hasn't noticed yet, this is from 2004. And so Dr. Collins probably had this idea a few years before that. So he was looking into this 20 years ago. 20 years ago, he was looking into this. And so imagine having this idea 20 years ago and then kind of thinking about where we still are today. It's concerning. So I wanted to highlight this as at least a rapidly expanding area of research, no doubt. Dr. Collins and Dr. Matoba in 2017, and some of these, bear with me if I read them word for word. I just wanted to really highlight these as much as I could, but they found that African-American infants have significantly worse infant mortality than white infants. But that like individual risk factors alone don't really explain this gap, just as they didn't really explain the gap in preterm birth and low birth weight. But that experience of racism is a recognized stressor for women with damaging and measurable consequences to their health and the health of their children. So interesting, sad, terrible. There's a million adjectives you could go towards, but it's noteworthy, no doubt. So I wanted to highlight again. I could put 100 papers up here, but just wanted to highlight a couple. There's one from Women's Health Issues in 2018 that there was like a survey weighted regression analysis between 2004 and 2012 in New York City. And they measured women that had experienced racism in the 12 months prior to delivery and kind of effects on their subsequent rates of preterm birth. And this is a direct quote from their conclusions that racism is an important public health problem with a measurable impact on preterm birth. So that was that one. This one also kind of mind-boggling. From the American Journal of Public Health in July of 2020, found that redlining practices from the 1930s, so almost 100 years ago, practices from 100 years ago, are still associated with contemporary risk of preterm birth, which is amazing in a way that I don't even understand. And they adjusted for maternal socio-demographic characteristics and still find an association and kind of increased odds ratio. This third one is from Pediatric Research in January 2020. And they found that racism and inequality definitely contribute to health outcomes and drive drive health disparities. And they specifically focused on preterm birth. So these are all interesting. Again, this is just the beginning. If you search this kind of thing and want to get into more discussion of this at a later time, there is a wealth of papers supporting all of these ideas just in the last few years, and probably sprinkled throughout the last 20, but it seems to be a lot in the last 2, 3, 4 years. So what about maternal health specifically? Because obviously maternal health is a primary driver of infant mortality. Dr. Melillo in 2020 gave a symposium, I believe, and it was later published in this journal. She noted that American women die in childbirth at a higher rate than any other developed country in the world, which is frightening. And it turns out African-American women are 3 times more likely to have a maternal death than white women in the United States. So huge discrepancy there. But it's, people might try to blame it on other factors, but really they compared, like I said, across socio-demographic factors and found that women who graduated from college have a higher risk of preterm birth than white women who dropped out of high school, which is surprising. They found that Black women are 4 times more likely to live in a neighborhood with high crime and air pollution, which certainly can affect their health and kind of health prior to beginning pregnancy. And they really highlighted that still to this day, where we live determines our toxic exposures. Even within one community like Louisville, living on the west side versus east side versus south side versus wherever can be a significant factor for your psychosocial stress, can lead to low birth weight and 100 other health disparities. So this is clearly a problem locally. Well, now that I've brought everybody kind of down and made everybody really sad, we're going to shift gears a little bit and kind of talk about how we're going to, I guess, combat this a little bit. So we'll kind of speed right through a list of local advocates that are kind of helping to combat this. So to tackle something as wide as infant mortality, we're going to have efforts at every level, from public policy down to individuals. So enter this Louisville Metro Health Equity Report in 2017. They give recommendations in all of these areas from public down to individual. So what about public policy? So it turns out we have a State House Democratic Women's Caucus that was formed this year that proposed several bills that focused on like the health of families and things like incarceration, mental health. So they're fighting that fight in Frankfurt, certainly. My new favorite representative, Ms. Attica Scott, who was kind enough to speak with me by phone a few months ago, has proposed several bills, including the Maternal Care Act, to help protect women who are pregnant and giving birth. She is pushing for a maternal fatality review team, looking for resources for access to doulas, and kind of implied and implicit bias training for healthcare providers. So there's a hint of public policy. In terms of the education realm, the CDC has 5 main areas that they think can help prevent preterm birth. It includes access to care, identifying women at risk, discouraging non-medically indicated preterm deliveries, preventing unintended pregnancies, and kind of changes in reproductive technology, which lead to a lot of multiple births. Sorry, we're speeding up a little bit. Louisville specifically has formed within their Metro Department of Public Health and Wellness. They established a Center for Health Equities, kind of the first of its kind in a municipal government setting, and they have as areas of focus maternal and child health, and have come up with this Healthy Louisville 2025 plan. They're tackling things like neighborhoods, environmental health, healthy schools, education, housing, all things that people mentioned earlier. So those are their main areas of focus. What about other local community advocates? Healthy Start is an initiative also within the Louisville Health Department Center for Health Equity. They serve those 5 zip codes in West Louisville that we highlighted earlier. And their main goal is strictly to decrease infant mortality. That is their sole focus. And they are focused just on those 5 zip codes to really target their intervention where it's needed the most. They do parenting classes and visits and promote healthy development, do a lot of safety injury prevention, provide resources for families. So a great advocate locally. Again, those 5 zip codes in West Louisville, 40203, 08, 10, 11, 12 is where they focus their efforts, and it matches up with, like I said, where the need is. Healthy Babies Louisville is another local community advocate that has decreasing infant mortality as one of their primary goals. They have a new breastfeeding task force that they're forming, but you can see some of their other goals there and initiatives that they're working on. And I've been lucky enough to be included in recent meetings with this group, so I'm looking forward to that in the future as well. That we have in the Kentucky-wide advocate, including one Kentucky-wide advocate is the HANDS program, so Health Access Nurturing Development Services, another home visiting program for pregnant and new moms, kind of promote healthy choices, healthy moms, and hopefully healthy babies. And there's their link there. They have a nice video you could look at later. There's a Black Mamas Matter Alliance by the Louisville Coalition for Black Maternal Health that has a maternal health week every April. So look out for that next year. There's another community advocate that I came across over the last 6 months or so. There's a group of medical students from the University of Louisville that it produced this incredible health disparity series with infant mortality as one of their main areas of focus. They have an incredible video. They put on an incredible series of videos. So I highly suggest you check out. These are incredible young people. I've met a few and discussed with a few by email. It is incredibly impressive and heartwarming and all the other good adjectives to see medical students kind of jumping on this health inequity. They have a pretty clear playbook for how Louisville can tackle this discrepancy and inequity. And some of it is access to care. Some of it is, what type of care we provide. Our healthcare givers addressing, and training about racism or not. But a lot of it is focused on maternal and infant mortality. So I appreciate their efforts. There's kind of nationwide advocates such as the March of Dimes that support research for preterm birth, amongst other initiatives. Some may wonder, like, what about these other causes? Are there any advocates kind of aiming their efforts here? And there are certainly. There's the Charlie's Kids Foundation to advocate for safe sleep, make sure baby sleeps alone, etc. They have a book that they give out to new parents. They have other fundraisers as well. Regarding the child abuse prevention, there's this entity called Prevent Child Abuse Kentucky. They have a wealth of training videos and other educational resources available on their website as well. What about organization level? So in terms of Norton Healthcare, what can we do? So in the primary care and OB/GYN world, we can screen and refer for things like postpartum depression, intimate partner violence, substance use. We can counsel about safe sleep, smoking cessation, breastfeeding, lactation support, pregnancy planning, etc. We can refer to WIC for nutritional services. All of those things help. Norton has a good online presence. Certainly, they have stories about sudden infant death syndrome or sudden unexpected infant death syndrome awareness, about safe sleep. They have social media presence, including Twitter, Facebook, and Instagram. They have an entity known as the Office for Prevention and Wellness that puts out lovely resources that you might see here, including those directed at safe sleep and tobacco cessation, etc. So we appreciate all their efforts as well. But what about our clinic specifically? We're nearing wrap up here. I know I'm flying through this, but this is one thing that I like to point out because they don't teach this in medical school, but it turns out that the clinical care that I can provide in the clinic accounts for maybe 10% of an individual's health. And again, I think some people come out of medical school thinking that we're gonna, be much more important than that. But I may account for 10% of a person's overall wellness and health. And there's a lot of other factors at play. So how can I, in this one little clinic, tackle this huge problem that's countywide and a big big force to be reckoned with? So let me give you a couple ideas about how our one clinic is kind of tackling this or attempting to. So one, we can provide trauma-informed care. So thanks to Dr. Pendleton and Dr. Morris and a host of others that have pushed for this, we can screen for adverse childhood experiences and in addition to violence, discrimination, housing and food insecurity, all of these things that can affect child and mother's health. And we think we can help prevent or reduce the health risks associated with these. So that's one thing, but how are we gonna address this specifically? So I put that over the picture of our clinic. We have this beautiful clinic, but we have this big problem in the county. So admittedly, a provider leadership academy requirement for me to have a performance improvement project was my motivating factor, but I knew that this inequity was a problem, and I didn't know what to do about it. But they say you can't improve something unless you measure it first. So I started looking into this last year, and it turns out that our clinic saw 200 infants from those 5 Healthy Start zip codes, almost half of our new babies. So these are our patients. This is our issue. This is our wheelhouse, right? So I thought, Healthy Start has this great program. They can get into people's houses and really kind of wrap their arms around these folks and kind of bring them closer to health and thriving and much better than I can in 10 or 20 minutes in the clinic room. So how come we're not sending every infant to Healthy Start? So I kind of looked into this a little closer, and it turns out we were not doing a great job of referring infants. I thought maybe we should address that. So we had a lot of room for improvements, it looks like. Because it looked like really only a couple of us were referring regularly at all, and certainly not as much as we could be doing. So without boring everyone too much about performance improvement methodology, we use this DMAIC method, which means define, measure, analyze, improve, and control. Went through all of our processes in this realm. We did this survey, looked at all the baseline data, identified some barriers, and mapped all these processes and proposed a bunch of solution sets. And long story short, the initial efforts are kind of in 4 main areas. we're trying to provide awareness and education for providers so they discuss it more with families. We're giving flyers and handouts to families anyway. We're trying to streamline our referral process in the EHR. And we're trying to we have forged a relationship with the Healthy Start representatives. Shout out to Mary Jolly and Lindsay Billieu. Thanks for all your efforts. And we kind of check in monthly and see how we can help each other. They need the referrals. We think it's quite helpful for our families to be referred. We just got to kind of figure out how to connect everybody. So that's been my goal over the last year, and will continue to be. We've engaged our resident physicians, try to make it interesting for them and educate them, and kind of help them help us bring this along. So I made a bunch of flyers and plastered them all over the clinic. You'll see one on the left here that I kind of made up and kind of made it seem so easy for our providers to refer. I put kind of a scorecard up in clinic. These are like poster size. There's a faculty one and a resident one. Obviously, we're not like competing. This is about patient health and well-being. We don't want to like make it a game, but it is a bit of a motivating factor to see your number go up over the years. So thus far, in a little over 4 months, we've sent almost 60 new referrals just from our clinic alone. And if we kind of extrapolate this out for a year and we continue our efforts, then maybe we'll get close to sending 200 a year. So my goal is that we send everybody that's eligible to Healthy Start, and because they have, like I said, the resources to get into patients' houses and really wrap these services around folks in a way that I can't do from the clinic room. So still to come in this project is measuring referral rates for individual providers and kind of make it a bit of a score and see how we're doing. We're going to make it as easy as possible with automated reminders within our EHR. Norton is planning to market these success stories and highlight individual families to kind of help buy-in from other caregivers, which we identified as a barrier. So what are the next steps? Address all the barriers to enrollment. But once we get our process all ironed out and smooth, we're gonna help spread it to other pieces or other aspects of Norton healthcare infrastructure. So if a family hears about this program in the OB clinic and in the birthing hospital and from the pediatrician, then maybe they'll be more likely to say, okay, we'll check this out and let this person into my home that I don't really know well. So that's the goal for the future. There's a couple other interpersonal efforts and individual efforts that I can mention, but I want to be able to get to any discussion. So I want to just highlight these last points to kind of sum up. I know I've flown through these slides a little bit, but what I want you guys to take home today is that infant mortality is affected by a lot of things, but this rate is what I consider unacceptably high in West Louisville. So this is a local problem. This is not just something that's for other parts of the country, and it's going to take public, community, organization, and individual level intervention. And one way to do it is kind of what our clinic has done, is kind of team with your local community advocate. I listed several for you. But that's one model to address this, because it's going to take a combination of factors to really affect change in something as broad as infant mortality. This isn't the only way you can do it, but this is one way. And I would just hopefully you can motivate people to step up and make some connections and help us tackle this issue and kind of bring these numbers down and address these inequities here in our community. So I think I may have gone fast enough to save some time at the end for any questions or discussion, McKenna.
Yes, you did, and we have a few.
Okay.
So let's see. So what is the enrollment percentage of patients referred? For example, of 60 patients referred, how many actually participated, enrolled in Healthy Start?
So it's not 100, I'll tell you that. And so I wish it was, but it's not. It's probably somewhere between 50 and 100, and it varies by month. So Healthy Start has been giving me this data, and basically the folks that haven't been able to be enrolled, we can get that information back from Healthy Start and discuss with them again at subsequent visits, because again, these infants may have up to like 15 visits with the primary care physician in the first few years of life. So we're going to use that information to say, oh, hey, you haven't enrolled with Healthy Start yet. I still think it's a great idea. I can re-refer and kind of discuss that with families. But it varies by month, and it is not 100%. So, but I don't have the exact numbers. We are going to try to track that a little closer using our electronic health record in the future, though.
And is that available in other counties or only Jefferson?
So Healthy Start is specific only to those 5 zip codes, but that's one health advocate, like I said, that's targeted their intervention where it was deemed to be needed the most. All of those other advocates that I listed are more broad and either countywide or statewide or nationwide. Healthy Start was just one example that we kind of wanted to partner with because of how involved with our patient population they could be, and how urgent of a need I thought it was.
Okay. What's your top referral reason, and do you refer for lactation?
We refer for lactation to lactation consultants, certainly. My top reason for referral is you're eligible because you live in these zip codes. I don't always get down to like, I'm not trying to offend anyone, but I just at least discuss referral with everybody that's eligible from those zip codes, because I think it can only be helpful. Even if a family knows everything there is to know about infant care and they're the most healthy, safe family you've ever met in your life, they could still bring you books for the infant. They could still bring you, kind of discuss other health things. It's only going to be helpful. It's not a punitive thing. So I refer everyone from those zip codes because I think it can only be helpful.
Thank you. For participants, if you could please enter your questions in the Q&A section instead of the chat, that will help me keep track of those. Is there an option or plan to have families enrolled while inpatient after birth?
Yeah, so I've met with some of the women's health leadership from the birthing hospitals like Norton Downtown that service this population, and yes, I think they are interested in that in the future, and enrolling maybe even before birth, like I said, from the OB offices, kind of getting people enrolled. Healthy Start will enroll folks prenatally, so I think the ideal place is probably the OB office. But like I said, sometimes it takes a discussion in the OB office, a discussion in the birth hospital, and a discussion with the pediatrician before we can, get a family to say, okay, I'll give that a try. But absolutely, in a perfect world, we will extend this to the OB office and people will be enrolled as soon as they get pregnant and go from there.
Okay. Are there metrics on single parenthood impact?
Not that I saw. I think there are. I don't have the specifics from that national vital statistics from CDC, though. I don't have those at this time.
Okay. Do you have Healthy Start staff on site to help invite families?
No, that is not something that we have gone for yet, because we're obviously not the only clinic in the city that services this population. We have their official flyers and information, but we've not yet had anybody on site.
Okay, how many years has Healthy Start been in the community? Can you hear me? Dr. Kinney? All right, Lindsay, sorry, I apologize if I pronounced your name wrong, says 23 years. I have another one. Mary Jolly says 21. And I think that we may have lost Dr. Kinney. So for any questions, if you want to continue to enter those in the Q&A section, we will connect with Dr. Kinney following the program, and we will email those out to everyone. So thank you so much for your participation today. We will display a QR code for an evaluation and credit on the screen after we end, and we will also email that out as well. So again, please continue to enter any questions that you have. Our CME team will collect those. We'll get those to Dr. Kinney, and we will send those out following the presentation. Thank you all for your time today. We hope you enjoyed it, and please complete the evaluation. Thank you.